So I'm going to talk a little bit about specific quality improvement projects in India that I work on, but as it relates to hospital-based strategies. So we've talked a lot about chronic diseases, but there's also acute manifestations of them, like heart attacks and strokes. So, looks like and the talk is over. I like to start where I finish with this slide, actually, the take-home point, so in case anybody has to leave. But hospital-based quality improvement programs frequently are led by professional organizations, at least in the cardiovascular community in high-income countries. They're associated with improvement process and outcome measures. And as we heard in the previous talk, implementation science offers this promise that Tim said of translating knowledge into action, particularly in low and middle income countries where the gaps may be larger. And I want to talk a little bit about strategies to improve causal inference in complex interventions, such as interrupted time series design, cluster randomization, and stepped wedge, which can be useful, but aren't without their limitations. They're definitely not perfect. So Eric Peterson led a project called CRUSADE. Cardiologists love to give acronyms, and this one you can see at the bottom might be one of the biggest stretches. Can rapid risk stratification, unstable angina, non-STEMI suppress adverse outcomes and early uptake of ACC guidelines? I mean, CRUSADE, of course. So this was, these were data collected from about 5 years from 500 US sites. About a quarter of them were academic hospitals, and they collected data on over 200,000 acute coronary syndrome admissions, a mix of non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Lots of publications, and they were able to flip this program where initially the doctors and hospitals would sometimes have an incentive, sometimes financial, to submit their data to what's called the NCDR Action ACS Registry, where now the hospitals pay to have their data analyzed so they can evaluate how are they doing in terms of their process measures and outcomes. And I think that's a major flip because the work that I do in India has been predominantly paying the hospitals to give data. And so you're trying to say, well, how are you going to ultimately make that sustainable? And in the US, I think the professional societies have been successful. In the state of Kerala in India, the cardiologists are very organized and they're very motivated. They want to deliver world-class care. And so I think sometimes that might be a carrot, at least in other NCD communities outside of cardiovascular medicine. So this is one of the key findings from the CRUSADE registry. What you have is a composite quality quartile on the x-axis here, ranging from less than 25% to greater than 75%. On the y-axis, you have in-hospital mortality. And what this is showing is adjusted in orange and unadjusted in yellow. So hospitals that have a lower adherence to hospital quality process measures, these are guidelines basically, do they implement guidelines, have higher rates of in-hospital mortality. So if you're more adherent to guidelines, you have lower mortality rates. But does this mean that causes it? I mean, guidelines have a great evidence base, but are there things that are happening in these hospitals besides the application of guidelines? So I think many people assume that's the case, and they said, well, for every increase in guideline adherence by 10%, there's a 10% reduction in mortality. I'm not so sure that we can make that link necessarily, and so I think other strategies may be employed. One thing that's been terrific with the Action Registry, these are data time on the x-axis and the proportion of patients who are receiving what's called defect-free care in whites, blacks, and Hispanics. In 2002, the first quarter, there seems to be a relatively wide gap between defect-free care in Hispanics compared to whites and blacks, whereas over time, sort of a rising tide lifts all boats. So there's a reduction in differences and potential disparities and improvements across the board. So quality improvement, who doesn't like it? It's as good as apple pie, but trying to figure out what are the bits that you can take to different settings, different hospitals, that's the tricky part. So in the US, there's been CRUSADE, Action, Get with the Guidelines, and now there's been publications from Brazil, something called the Bridge ACS randomized trial. It's a cluster randomized trial. There's the clinical pathways in acute coronary syndrome 2 and 3 in China. 3 is ongoing. And in India, we're working on the acute coronary syndrome quality improvement in Kerala. With Brazil, China, and India, there's a greater emphasis on evaluating the effect of the interventions. And so some of the strategies that are employed are things like empowered interdisciplinary quality teams with regular meetings, standard admission and discharge order sets, clinical algorithms. These seem to reduce the rate of complications, and then audit and feedback mechanisms. And there are strategies to optimize audit and feedback. Some of the key goals of our toolkit in Kerala have been to first identify and train teams at each site. Now that seems like, well, aren't you going to have contamination if you're training both the intervention and the control? But I mean, my estimation of education alone is necessary, but by itself is insufficient to drive change on a large scale. We're trying to target specific areas of improvement based upon prior research, and I'll show you data from the Kerala ACS Registry on why we're choosing inappropriate thrombolysis, suboptimal use of quote-unquote inexpensive medicines, and trying to minimize delay for decision-making, particularly on these time-sensitive patients who have ST segment elevation myocardial infarction. We're using systematic reviews to inform the strategies to overcome some of these problems, and we're trying to adapt with innovative ideas. So we talk a lot about fixed-dose combination therapy for chronic management of cardiovascular disease, but what about inpatient management? There see drops in care as we get more complex, adding more and more medicine, so potentially simplifying in-hospital care as well. In Brazil, Berwanger and colleagues use a bracelet method where red, yellow, green. Now, I'm not so sure how translatable. If you put a red bracelet on me, I say, what's going on here? Oh my gosh, am I gonna have to get defibrillated pretty soon? So I have to contextualize these things. So the cardiologists from the Cardiological Society of India Kerala chapter had collected data on more than 25,000 acute coronary syndrome patients over 2 years. So there were errors of both commission and omission. So red, ST segment elevation myocardial infarction, gray, non-STEMI, black, unstable angina. So for patients receiving thrombolysis, these are clot busters. This is indicated only in patients with STEMI, yet about 1 in 5 non-STEMI patients received thrombolysis. And when we look back at the EKGs and said, why did this happen? These were EKGs that were scary-looking non-ST segment elevation myocardial infarctions that some of the GPs who were caring for the patients in hospitals without cardiologists said, well, what am I supposed to do? Am I supposed to wait for the patient to develop an ST segment myocardial infarction, or do I treat? So there's a rationale, but we hope to be able to minimize this because this was associated with worse outcomes. On the other hand, there are errors of omission in hospital diagnostics and treatment. So these are things like beta blockers, statins, heparin, for example, practically 60% of STEMI patients, whereas heparin reduces the risk of recurrent infarction. So these are the outcomes in hospital. Red, again, is the STEMI patients, gray, non-STEMI, and then black is unstable angina. So the death rates here are more than 8%. So for our intervention, we really want to focus on STEMI and non-STEMI patients. This is about double what it can be in the US, suggesting that there's room for improvement. Whereas unstable angina, very low event rates that are going to be difficult to improve upon. So not a primary focus. So Tim had talked about the cascade, and this is not too dissimilar. What we're trying to figure out is, is there a single drop-off in medical care in the hospital, shown in black, or at the time of discharge in red? So on the x-axis, so these are different drug combinations. C is clopidogrel, A is aspirin, S is statin, H is heparin, B is beta blocker. And this is the proportion of patients receiving this. So the cardiologists are really good in Kerala about giving patients aspirin and clopidogrel, about 90%, which is about as good as you're going to find anywhere in the world. At the time of discharge, this drops pretty dramatically to about 70–75%. So in focus groups and in-depth interviews, there's a lot of discussion where the cardiologist will say, patients just can't afford this. It makes no sense for me to give a prescription. But even in the hospital, at the addition of medicines like aspirin, clopidogrel, and statin, we're now down to 75%. So it's a pretty gradual, as you add more medicines in the hospital, they're less likely to be given. So that's this whole concept of, could a polypill be used in the hospital? Most of the cardiologists aren't too interested in that, but I think it's an area for future study. So let's try to figure out what are the methods to evaluate the effect of potential quality improvement interventions. So one is something like a controlled before and after study. And before I had started to do this, I remember meeting with George Davy Smith, who said, you cardiologists always just do this. You do before and after study and say, hooray, we did it, right? But in a country like Kerala, or in a state like Kerala, things are changing really rapidly. The Kerala ACS registry data from 2007 to 2009, there's more than tripling of the number of cath labs that are available in the state. So it's hard to know, did your intervention really have anything to do with changes in outcomes, or was this simply because of secular trends, where you're measuring something just before and after? Alternative strategy is something like interrupted time series design, where you take multiple measurements before the intervention and after, and try and evaluate the differences in slopes before and after the intervention to demonstrate an effect of the intervention. Randomization is preferred whenever possible, and that's one of the recommendations from the MRC's recommendations on complex interventions. The challenge with randomization can be, do you want to be randomized to quote-unquote usual care? Hospitals may say, well, I want to be part of the quality improvement team. Like, who doesn't want that? I don't want to be, if usual care is so crummy, why is this really ethical? So one of the strategies that we've employed is a stepped wedge design, where at the start, all hospitals are in the control or the comparator group. Then at predefined steps, hospitals move in a one-way crossover design to the intervention and stay in the intervention for the rest of the time period. At the next step, another round of hospitals move from the intervention to control, and these are randomly selected hospitals, and they stay in the intervention for the remainder of the trial, and so on and so forth until the final step. All hospitals are receiving the intervention, and the event rates are compared in the blue against the event rates in the white. So the advantage of this is that all hospitals ultimately receive the intervention. It's sometimes more politically acceptable or feasible. This concept was developed in the 1970s in the HIV community in Gambia during the rollout of hepatitis B vaccinations. So, but the challenge with this is if you are having difficulty enrolling, some clinical trials will extend the time at which participants are being recruited. You can't really do that. Also, there's a design effect that increases your increases your sample size. So there are multiple, while the step wedge is very attractive scientifically, practically it can be difficult, I'm finding at least, to implement. So in Kerala, these are our aims, trying to develop, implement, and evaluate a QI toolkit on 30-day MACE rates, or major adverse cardiovascular events, using this cluster randomized stepped wedge design. We're looking at patient-reported outcomes using a translated Seattle angina questionnaire. It's not known after patients in India have heart attacks, what's the rate of having disabling chest pain? So trying to get a handle on that. We're also interested in looking at the individual and household level economic effects of acute coronary syndrome in the context of evolving health insurance schemes in India. We've done some previous work that's looked at the catastrophic health spending and distress financing that occurs after hospitalization. Having stents put in can sometimes be expensive and financially ruinous. So some patients will borrow money or sell assets just to simply take care of themselves. And then along the way, performing focus group discussions with clinicians to define optimal ACS care. What should the standard be in Kerala? And trying to get specific feedback on facilitators and barriers. So this slide just really summarizes some of the strengths and limitations of different study designs that I think in this context of greater emphasis on implementation science, this is just a few, there are others, but interrupted time series design is simpler, frequently cheaper, but to potentially lower causal inference. It depends upon a question earlier about sort of the life cycle of an intervention or the life cycle of changes. Some can be very rapid, whereas some can take a lot of time depending upon your outcomes. Cluster randomization helps minimize contamination, and it's often essential when the target is part of the health system, but there is an increase in sample size that can occur. The step wedge design is politically often more feasible and acceptable, but it's really the sample size is really sensitive to the ICC and the design effect of step wedge, and you can't extend the trials, so you gotta kind of nail it right the first time. So back where we started, which is now here at the end, really the end this time. So hospital-based QI programs are frequently led by professional organizations in high-income countries, and they're associated with improvement process and outcome measures. The implementation science offers the promise of translating knowledge into action, particularly in low and middle income countries, but I stress the importance of using appropriate study designs and randomization whenever possible to really tease out what is working here. And strategies to improve causal inference in complex interventions include interrupted time series design, cluster randomization, and step wedge are useful, but not without their limitations. So thank you very much for your time and attention, and I look forward to question and answers.